Hi everyone. This is the lecture for treatment planning for kids and adolescents for pre-practicum. You'll see that treatment planning for kids and adolescents, there are some things that are definitely the same as we do for adults, and there are some things that are different. So we're going to talk about those as we go through this talk today, this slide deck. So let's start with some national mental health data. The data around kids and adolescents is sad, which I'm sure all of you guys know. It's gotten worse since COVID, but this data comes from the National Institute of Health and the CDC, and it gives you the breakdown of the percentage of kids that are diagnosed, so kids ages 0 to 18, who are diagnosed with the disorders that you see on your screen. The operative word is being diagnosed because we know that access to treatment is sometimes difficult for kids and adolescents. And so the numbers here only represent those that have been diagnosed. So ADHD is 9.8% of kids, so approximately 6 million kids. With ADHD, there's a lot that comes with that. There's a lot of overdiagnosis with ADHD. There's a lot of medication issues that come up with ADHD, but that number of diagnosis is pretty big when you're thinking about 6 million kids. Anxiety, 9.4%. Behavior problems, 8.9%. So that lumps in any sort of kind of symptom or criteria that you might be seeing. Depression, 4.4%, so approximately 2.7 million kids. Suicide is the second leading cause of death among children aged 10 to 14. The first leading cause of death is car accidents. So suicide is right up there, and is super scary. If you think about a kid that's 10 years old wanting to take their own life, that feels really, really scary to me. Here's some more data. So boys are 2 times more likely to have a mental, behavioral, or developmental disorder than girls are. Among children living below the federal poverty level. So that's 16.9% in the United States and 18.5% in New York State. More than 1 in 5 have some sort of diagnosable mental, behavioral, or developmental disorder. That's a lot of kids. That is definitely a lot of kids. So thinking about the kids that you work with or the kids that are in, the population that you're going to work with, thinking about their socioeconomic status is really important. Age and poverty levels have the most impact on access to treatment. So we see that in our urban and our rural settings. Definitely, there's a lot of co-located services in schools now, but it's hard for families to get kids into treatment, especially if poverty comes into play, because with poverty comes trauma, and with trauma comes, all those kind of symptoms that are coming up, and then access can be really hard. So things like transportation or insurance coverage, all of those factors influence the national mental health data. So I want to back this up for just a second. Let me exit full screen, and I'm going to back it up, and I'm going to pull this one back up for you. So I want to show you, this is a really good resource. This is from the CDC, and it's linked right into this PowerPoint, but it talks all about children's mental health. This is a great website because things are constantly changing, and this is always updated, but it tells you common child mental health disorders. It tells you symptoms, how they're treated, and then where you can get help finding treatment. So this is twofold. It's a really great resource for families if you're working with families. It's also a really great resource for you looking for a job, right? So if you want to continue to work with children and adolescents, you can click on these links and it'll tell you where settings are located where you can do that. So this is a really great resource. It also has all of these free resources on here for you. We've talked about before, this bridge program is a generalist program. So if you want to specialize in kids and adolescents, you're going to have to get more training beyond just this bridge program. So this is a great place to help you to get training as well. So just familiarize yourself with this website, I would say. Okay, so back to this. So as we know, mental health disorders look different in kids than they do in adults. So there's 3 of them that we're going to break down here. And the purpose of breaking this down is when you think about treatment planning, you have to think about planning with the whole family when it comes to kids and adults. Kids live within the context of their families, so we need to be partnering with families. We also need to be partnering with pediatricians. We need to be partnering with schools. And a lot of times you're going to be the expert in the room, right? So you're going to be the one that's talking about how symptoms might look different in adults and kids. So when we think about anxiety, and these came, this comes from the diagnostic criteria and what that diagnostic criteria looks like in action. So think about you as an adult, how you feel when you're anxious. What does that do to your body physically? How does it change your behavior? How does it change how you socialize with others? What does it look like? How does it change your thinking? And what are your coping skills like? So as a grown-up, right, hopefully, you're more able to recognize the connection between anxiety and any physical symptoms that you have. For kids, it's really hard to communicate those physical symptoms. So you might see kids that are complaining of a lot of physical symptoms, or kids that are going to the doctor a lot, or kids that are going to the nurse's office a lot. That's a really good thing to monitor when you're working with kids and families. Behaviorally, as an adult, I'm a very anxious adult. So sometimes you get avoidant, you don't want to be in social situations, you feel like people are judging you. In kids, you might see some regression in behavior. So things like thumb sucking, bedwetting, clinginess, right? Separation anxiety is a big one. They might get really clingy to their family. In the social realm, adults are more likely to call in sick to work. They're more likely to avoid their friends and their family. Kids are more likely to avoid school. So you're going to see it in absences. So it's important to ask about absences to school. Expression in adults, you might see shaking, pacing, limited eye contact, all of those things that come with anxiety. In kids, it looks more like crying and tantrums and irritability. Cognitively, as an adult, you might have racing thoughts, you might have intrusive thoughts, you might have some cognitive distortions. And kids are having all of those things as well, but they're not able to put into words a lot of times, like what's happening inside their brains. So you might see a lack of concentration and focus, or this is a big one, you might see kids trying to be perfectionists and get everything right and have a really big fear of mistakes. And then coping strategies, sometimes the coping strategies that work for adults are not the coping strategies that work for kids. So for adults, you might do talk therapy, medication, mindfulness, exercise, and you just have to look at the developmental level of the kid and modify your treatment. So play therapy or comfort objects are a big one. Kids obviously can still do mindfulness and exercise and those types of things, but just knowing that when you're thinking about your treatment planning, you need to look through a developmental lens. The next one is depression. And again, depression looks different in kids than it does adults. So in adults, you can communicate sadness, hopelessness, or despair. When I work with clients, it's usually, depression is on the spectrum from I feel really sad to I feel nothing, right? So the sadness and numbness kind of thing. In kids, they might have difficulty expressing their feelings verbally, but they might be irritable and cranky, and they might appear sad to you. Physical complaints, again, headaches, stomach aches, fatigues. Adults are really good at linking their physical complaints to their mood sometimes. So just listening to kids, and again, asking the nurse, asking the parents, are they often at the doctor's? Do they have to go to the nurse's office all the time? Play and activity. So the key component to depression is anhedonia. So loss of interest in things that you used to like. So loss of interest in hobbies, not going to work, loss of interest in socialization. And kids, you might see them, they don't want to play anymore. They have decreased energy levels. They might be really tired. They might be sleeping a lot when they're depressed. Academic and work. You'll get a decline in work completion from kids, frequent absences, a difficulty concentrating and focusing. Social behavior for adults, you might see withdrawal, isolation, and strained relationships. In kids, you might see difficulty making friends, or it might come out the other way, and kids might be super aggressive towards friends, or a high level of irritability. And then suicidal thoughts. So when you're working with depression in kids or in adults, you always want to keep in mind suicidal adult thoughts. Usually adults can communicate those thoughts. They're present and they can communicate. Kids, they're present and they're sometimes harder to communicate. So we have things in place like risk assessments. For little kids, ages kind of 0 to 10, risk assessments can be really hard. The National Institute of Health is working on a risk assessment for little kids, but it looks more like a clinical interview. For kids 10 and older, a risk assessment like the Columbia Suicide Severity Scale is a really good one. And I'm sure that you guys have used risk assessments in your work as well. And then lastly, ADHD. So ADHD in adults, definitely on the rise. And it looks a little different than ADHD in kids. So you have the criteria hyperactivity and impulsivity. So in adults, usually adults are not hyperactive. Usually inattention is their prominent symptom. But in kids, you might see them fidgety, interrupting, they can't sit still, trouble taking turns, lack of thinking about consequences. But remember too, that the kid's logical brain does not develop until you're about 26 years old. So it is normal for little kids to be fidgety, interrupting others, not sitting still, taking turns, lack of thinking about consequences, especially teenagers, lack of thinking about consequences. So as the mental health counselor, it's really important for you to tease out which of this is normal developmental behavior and which of this is something pathological. Academic and work. So adults might have difficulty completing tasks or staying on topic at work. Kids might have difficulty with their schoolwork, their organization, attention, focus, following instructions, losing materials. ADHD is probably the most overdiagnosed thing that's going on for kids. I know that a lot of well-meaning teachers in schools like to say, this kid has ADHD. It's our job as the mental health counselor to help folks understand it's not their job to diagnose, it's your job to diagnose. So helping them to identify the differences in behavior would be very helpful. Peer relations, adults might have difficulty with communication. It's hard for them to follow through. Kids might have difficulty making and sustaining friendships and difficulty taking turns during play. Again, this might also be developmentally appropriate. So if you've got a little kid that's never been in school before or never been socialized before, it might be hard for them to take turns. We're seeing this a lot now with COVID babies, like babies that were born during COVID and didn't have any socialization, maybe outside their little pod or outside their family for the first 3-4 years of life. And then they get to school and it's really, really hard for them. Does that mean they have ADHD? No, absolutely not. But something is definitely going on. Academic and work. So you might see job instability from adults and disorganization. In kids, a decline in work completion, again, frequently absent. They're not able to concentrate. They're not able to focus. Their grades are going down. Time management is a big one, and adults are not able to complete their tasks. And kids, it might show up as frequent lateness and disorganization. And then their emotions. I thought this one was super interesting. In adults with ADHD, they have a higher risk of traffic violations just because of lack of concentration, and they're just difficulty staying on task. And then kids might have frequent outbursts. So here's the thing though, you can probably see that there's a theme, and we're just looking at these 3 disorders, and there's a theme with kids that sometimes things look the same. So it always impacts their schoolwork, right? It usually or always impacts going to school, absences. It usually always impacts social relationships. It impacts their moods. So they can be irritable, they can be sad. Organization, so executive functioning is impacted. So in kids, symptoms of different disorders look the same. So it's your job to provide a really thorough assessment, a really thorough diagnosis, which will then lead to a really thorough treatment plan. So I want to talk to you a little bit about trauma and the brain. You will cover trauma in problem ID 1. And I'm sure that you're all familiar with ACEs, but I'm going to show you a video and we'll talk a little bit about the brain real quick. So I'm going to show you this video.
Brain development is much more than a story about biology. From the earliest years, relationships with others play a key role in shaping how our brain grows and develops. Early relationships, where there is abuse and neglect, have a long-term impact on children. A brain that has adapted to survive in a threatening or unpredictable world may not work so well in an ordinary environment. This can create what is called latent vulnerability, where early abusive or neglectful experiences with carers put children at greater risk of experiencing mental health problems in the future. For these children, compared to their peers, common experiences like moving to a new school can feel more daunting and stressful. New faces can appear threatening, while positive social cues can be missed. It can be harder to negotiate new social situations and learn to trust new people. Even fun experiences like joining a new sports team can be challenging. Too much focus on potential threat cues can mean missing out on positive social cues such as a playful nudge. Or it causes an overreaction, which leads to an increased risk of conflict and sometimes violence. These reactions can increase the likelihood of generating new stressful events. It's harder to deal with everyday challenges when you feel unconfident and anxious inside, and harder to build and maintain relationships. Over time, this can mean a child loses friends and the support of adults, and so misses out on opportunities to grow and develop. This social thinning can increase the risk of mental health problems in the future. Neuroscience research is beginning to shed new light on how vulnerability unfolds over a child's life. All children need care and stimulation from adults who value them and who show them attention and love. These experiences shape a child's brain development. When children face traumatic experiences like abuse and neglect, their brain adapts to help them cope. We know of changes in 3 different brain systems: the reward, memory, and threat systems. Experiences of domestic violence or physical abuse can lead to hypervigilance, where the brain reacts more to threat. This might help a child stay safe in an early adverse environment, but it can cause problems in more ordinary environments. Hypervigilance can best be understood as a pattern of adaptation rather than a sign of damage. Abuse and neglect can also mean a world where a child's basic needs for care and attention are not met. This can shape the brain's reward system, the part of the brain that helps us learn about positive aspects of our environment and motivates our behaviour. Over time, the brain's reward system can learn to respond differently to things like positive social cues. Neuroscience studies have also pointed to changes in the autobiographical memory system, our memory of everyday past experiences. Following trauma, negative memories appear to become more salient, which means they become more prominent than positive ones. And everyday memories can also become less detailed. This is a problem because we need to draw on past experiences to help us deal with new social situations. Neuroscience research is showing how childhood trauma can create latent vulnerability, increasing the risk of later mental health problems like anxiety and depression. This vulnerability is not just located in the child, but arises through their relationships. Helping children who have experienced trauma still requires ordinary boundaries and consequences, but it also requires us to step back and reflect and see behaviour that we find challenging in a different light. A child may simply be doing their best to survive now, with brain adaptations from the past. We know a child's brain has the capacity to continue to adapt. For this to happen, they need our help to build and maintain trusted relationships, manage everyday stresses, and prevent new ones from happening. We need to encourage them to try again and believe things can be different. This is far from an easy task and takes time. Science is helping reframe our understanding of childhood trauma. Seeing children's behaviour in a new light can mean we respond differently. But there is much still to learn. Working together, we can develop more effective approaches that promote resilience and recovery. We can help children build trusting relationships and create opportunities for their brains to adapt in new ways.
So the first 4 years of a child's life can affect brain development and have a significant impact on later emotional, mental, and physical well-being. And the effects, as you know, can persist into adulthood. And especially the first 8 weeks of an infant's life is especially vulnerable to the effects of traumatic experiences and the effects of complex trauma. So in order to understand that, you have to understand the brain. And this is helpful for you in treatment planning because part of your treatment plan can be psychoeducation with parents, psychoeducation with caregivers, psychoeducation with schools around what trauma does to a brain. So when you think about the brain develops from the bottom up. The brain stem, which is down here on this picture of the brain, is the lower part of the brain. It develops first and it controls responses to survival and automatic responses such as breathing, sleep, and temperature regulation. The limbic area of the brain, right? This is the second part. This is the amygdala, the hippocampus. The amygdala is like the brain's smoke detector and plays an important role in the regulation of emotions, memories, and survival instincts. And the hippocampus connects the lower and upper parts of the brain and is important in the expression of emotional and in memory function. So when people respond to real or perceived stress, the hippocampus releases a hormone called cortisol, which helps regulate the response to stress. And then the upper part of the brain, this cortex, this develops last. This is described as the watchtower, and it's responsible for our ability to pause, to think and reflect, to concentrate, to problem solve, all of that executive functioning kind of stuff. So the prefrontal cortex works with the amygdala to regulate both your emotions and behaviors. So what happens when a child is exposed to trauma? The lower part of the brain responsible for survival is repeatedly activated, and prolonged in infancy and in early childhood, this can reduce connections between other parts of the brain. It can significantly impact a child's ability to learn, to form memories, to regulate emotions, their ability to be calm, to learn, to think, reflect, and respond flexibly and in a planned way. So what happens is that every time a stressor or a trauma occurs, right, a kid can go into fight, fight, freeze, or fawn. That's the newest one, behavior, and the changes that does in your brain. So this picture, I'm sure you've seen it before on the right. It's a very old picture. It's been around forever and ever, but this is a 3-year-old on the left, a normal, quote unquote, 3-year-old's brain. And you can see the size and you can see the ventricles and you can see what a brain looks like. And then this is a 3-year-old with extreme neglect. So not only is the size of the brain physically smaller, but this gray matter is bigger. The prefrontal cortex almost looks atrophied around the brain. So when you are thinking in terms of treatment, if you're working with a child that has experienced trauma, you have to take the brain part of it into consideration when planning out your treatment strategies, especially around psychoeducation and around consulting with adults. So what does that look like? It looks the same for kids and adults in terms of your planning and your SMART goals. So just to remind you, and this is linked in here, here are your SMART goals. And we talked about this last time, how to develop a SMART goal, what SMART stands for: specific, measurable, attainable, relevant, and time-based. And you're going to be developing SMART goals for the client in this week's example. So the treatment plan, which is not coming up, but it can come up here. The treatment plan is going to look the same as well. So here's your treatment plan. And this is linked into Blackboard. So your client's name, your history and demographics, assessment and diagnosis, presenting concerns, strengths. Strengths are so important. You know, just when you're talking with clients, you want to kind of sandwich everything in between their strengths. Treatment goals, objectives, modality, frequency and target, interventions, and progress and outcomes. So the template is going to look the same, but the way that you go about it is going to look a little bit differently. So when you're working with kids and adolescents, you want to make sure that you're doing collaborative treatment planning. You want to involve the child and adolescent in the treatment planning process to the extent appropriate for the developmental age. You want to encourage their input and encourage their preferences. right? Kids are not going to change. Behavior is not going to change unless kids have input into that. That's going to look very different in a 5-year-old than it's going to look in a 15-year-old, however. So you want to make sure that you're involving the child or adolescent as much as developmentally appropriate. You want to make sure that you're engaging families, so parents and guardians in the treatment planning process. Families can provide valuable insight into a child's history, into their daily life, and into specifically how well any sort of treatment is going to work. So kids, just by being in your office for 45 minutes to an hour every week or every other week, that's not going to make them, it's going to help, but what they do outside of the session is going to be the most important for change. So you need to talk to families about being consistent, about being reliable, about having input into their child's treatment plan in order to be successful. Consider involving other relevant professionals. So I would go even further and say you must involve other relevant professionals, teachers, pediatricians, school counselors. Kids live within the context of their families and of those systems. They might be with you 45 minutes to an hour a week, but they're in school, 6 hours times 5 days a week, and then they're with their families the other part of the time. So making sure everybody is involved. And then when you're treatment planning for kids, you really want to look at evidence-based interventions. So again, this is a generalist program. So if there's an intervention that you feel like, oh, this is something that I really want to learn about, it'll be on you to get that advanced training once this program is over. But looking at what specifically works with kids. So CBT, play therapy, family therapy, social skills training, medication management. So you do not prescribe meds. It's not within your scope of practice as an LMHC, but you definitely work in consultation with pediatricians around medication management. When I was in private practice, I did a lot of medication management, especially for kids with ADHD. So you'll work with pediatricians in that. When thinking about trauma, there's a lot of really great trauma evidence-based interventions. So trauma-focused CBT is a really great one. Child-parent psychotherapy is a really great one. Interpersonal psychotherapy is a really great one for depression. So just making sure anything that you're doing is coming from an evidence-based lens. And then consider the child's developmental stage and adapt interventions accordingly. You also want to consider if there is any sort of developmental delay going on with kids. Treatment for a child on the autism spectrum is going to look very different from a child who's dealing with just anxiety. So there's a lot of factors that play in there, and you want to make sure to have all the information about this kid's life. So that's why the collaterals or the relevant professionals are so important. And then making sure your cultural competence and your ethical considerations. So really thinking and getting supervision around a child's cultural background, especially if it's different from yours, thinking about the values of the family that you're working with and how those values align or don't align with your treatment planning process. You want to always adhere to ethical principles. You want to really make sure that you are abiding by the laws in the state in which you're practicing, right? New York State, 12 years and up. Parents need permission to see their kids' records. So making sure that your informed consent covers all of that. Talking about confidentiality, when you have to break confidentiality, what that looks like. Making sure that kids know that you are not going to keep their secrets. Even in private practice, you're not keeping their secrets. So just making sure that you have that conversation. And then regular review and communication. So you put a treatment plan in place, you want to make sure that you have benchmarks in there and that you're following up when you're going to assess progress. You want to make sure, again, that goals are measurable and that they're attainable. If you need a refresher of this, you can watch last week's videos. But we want kids to be able to succeed. You might have to put rewards in there for kids, but they need to be part of the process in deciding what the reward is going to be. And then you want to make sure that you have open and effective communication with everybody that's involved, including teachers and other professionals. So I would say when you're working with kids, you want to get your releases signed right off the bat. You want to release to the pediatrician. You want to release to the school if they're involved in any sort of law enforcement. if they're involved in the foster care system, anybody, CPS, anybody, you want to make sure that you have releases in place so everybody can be on the same page. So that's it for treatment planning with kids and adolescents. There are 2 assignments this week and then 1 discussion question. And then that will wrap up our 2 modules for treatment planning. If you have any questions, please reach out anytime. I'm happy to talk them through with you.